but you develop, if you don't have it to begin with, like parental training or whatever, you develop an aversion to the physiological arousal, so that part of what you have to do to get over the anxiety is to get used to the feelings that are associated with panic and to get used to being anxious. And they'll actually, some of these things there's no way I'm going to do with an older adult, but with younger adults they actually try to induce things, like they induce dizziness by having you spin around in the chair, or you induce hyperventilation with rapid breathing and stuff. Yeah.
I'm just wondering about the drugs that are prescribed for anxiety. My understanding is that they help sort of lessen the physical symptoms. Yeah. So then you can deal with it through cognitive behavioral therapy. Is that not?
That's what people would say.
Okay.
That's the most common traditional rationale. What Michelle Krauss would say is that if you're doing that while you're in therapy, because you're not experiencing the physical effects, you don't get the learning of how to deal with the physical effects, and so you don't get desensitized to them and get them back down to a normal level. Now, I can imagine people being so paralyzed with anxiety that you wouldn't get them started without all of the tranquilizers or something first.
Is she talking about, I mean, what about general anxiety disorder, which doesn't have, I mean, is she suggesting the same thing for that, or just more for phobias?
She focuses mostly on things that involve panic.
Oh, okay. So she's talking about like panic attacks. Oh, okay.
And dealing with worry, although you might go through a phase, actually, if you start, in principle, if you stop the worrying, then the physiological arousal might go up. Because the reason...
Well, then you worry that you're not worrying.
Yeah, you can do that. Supposedly, what keeps the worrying going is people's at least belief that the worry is blocking the physiological arousal. It does seem to work in that limited way. And so there are specific interventions with young adults for GAD and kind of steps for tackling that. With older adults, the whole thing could be different because we know, as we talked about in the emotion lecture a couple times back, we know that the physiological arousal component is dampened down physically. What's much less clear is whether the subjective sense of anxiety is dampened down or not. It may be that older adults are in just as much subjective pain at lower levels of subjective arousal. Or it might be that they're also experiencing less subjective distress associated with physiological arousal. You might know what underlies that. Sleep restriction, sleep compression therapies, and multi-component cognitive behavioral treatments for insomnia. One of the things that has intrigued and bugged me for all of my professional life in clinical geropsych is that if you go and look at the physician's desk reference for every sleep medication that's ever been created, it says that you should take this medication for no more than 7 to 10 days. And it goes on to tell you that if you take it chronically, that it leads to sleeping problems. And a huge percentage of every older adult I've ever known has been taking sleeping medications for years. So I think this is an area where sleep hygiene education, which is what a lot of this comes down to, and psychoeducational interventions could really do a lot for sleeping problems, I think. I mean, to start with, one of the biggest things I've seen on a routine basis is people go to sleep at 7 and want to know why they're waking up at 3.
I had a roommate that was like that. He'd come home every day and take a nap at 5:30 for 4 hours. And then he'd be really pissed at 2 in the morning when he couldn't sleep, so he started taking Ambien. Yeah. I told him if you don't take a 4-hour nap at 5 o'clock, you might be able to sleep.
And you get that too with older adults. You get people who, for whatever reason, come home about 1 in the afternoon, sleep for 2 or 3 hours, and then wonder why they can't sleep 9 hours at night. So part of it is just actually finding out how much people are sleeping, whether what they're doing makes any sense. Then you get into the discussion of, I go to bed at 7 because television is really boring at 7. And I say, it's even more boring at 3 a.m. Don't you find? There's just a variety of things that you can do. The sleep restriction kind of ideas, you decide when people are going to get up, and you always get up at that time, and eventually you get tired enough that you go to sleep and you get a decent time, and you can get yourself back on the regular schedule. You don't use any naps. If it gets more than that, if people are waking up in the middle of the night worrying and stuff, there's some things you can do to interrupt those kind of patterns.
For putting someone on sleep restriction, do people usually have a lot of resistance to that?
People resist everything.
I tried to talk my roommate into doing that at one point, and he would not do it.
Should have just poured him a cup of coffee at 4 o'clock.
He wouldn't drink it. He would only drink sweet things. And we didn't have enough sugar in the house for him.
One of the things I often tell the trainees that I'm teaching to do therapy is that an awful lot of therapy is like, you have this client that's like running into this brick wall, and the brick wall is about like 3 feet thick, but it's only about 5 or 6 feet this way. And as a therapist, you can say, you could like go around. And the client keeps telling you, no, I got to get through. And you keep having that conversation until they decide that maybe they trust you. That you kind of say, no, come on down here. You don't have to like go around the wall. Let's just come down to this end and we'll like work with it. Yeah.
I was wondering what you thought about the efficacy of music therapy.
There are a whole list of things that I think are really good to do in different kinds of contexts that I'm not sure why we call therapy.
Let's relax.
Yeah, I mean, I think music is great.
No, but I mean, if you're tense, you call it therapy because it helps you relax.
Well,
Okay, whatever. You're the psychologist.
well,
What I'm telling
I
you.
mean, but this is
No,
just-
seriously. What am I? But there is
Aren't
some.
you just trying to form a pattern for going to sleep?
Yeah, because I do that every night. I listen to soft music. You know,
It works, that's great.
Well, it
It has
helps.
been used in nursing homes for the treatment of the problematic behaviors in Alzheimer's disease patients. It's been effective.
Again, I think there are lots of things that you can do and that people probably should do. So with some of them, I think calling everything therapy muddies the water on all sides.
Well, don't call it therapy. What do you think of music?
I think music is great.
It sounds like it goes back to the increases pleasant events. It's pleasant to listen to. They can dance if they want to. It brings back some nostalgic or some happy time of their life or something. It's a pleasant event situation, it sounds to me.
Has anybody read the book, Musicophilia?
No. Who wrote it?
I can't remember.
Musicophilia?
He's a psychiatrist and has done a lot of research
Yeah.
in music therapy for Alzheimer's and
Well, I think in
demented.
all kinds of milieu therapy, environmental therapy kinds of things can be really useful.
But it's music that they identify with. It's not listening to the junk that's on the radio today.
Oh, yeah.
That's the point. So it's a pleasant well, it's a pleasant event thing. It's a nostalgic thing. It's something they've experienced.
And tending to the
Another time.
individualized
Let
components
her
of
talk
it.
about it. She knows what she's
All I know is what, in terms of Alzheimer's disease patients, sometimes they can be almost catatonic, and about the only thing that will stimulate them is music. And perhaps it's music if they were very talented pianist that they have not played for like a decade or so. But if they start hearing a couple bars of familiar Brahms or Beethoven, they just turn on. I just think it's fascinating.
I've known caregivers that say that people can remember instructions or follow instructions better if you sing to them.
Have
in
you
a
had
particular thing.
patients like that? Where you've seen that with your own patients, or you read about it?
I've just mostly read about it. I mean, I've seen the relaxation.
That's also with stuttering.
Sometimes, yeah. I mean, whatever works is good.
Yeah, I was just wondering, nothing.
But people who stutter when they speak, they don't stutter when they sing.
I think it's some of them.
Most of them.
That's interesting.
This is BCO.
That is a therapy.
He's going to
It's a psychiatrist, actually.
And then finally, psychoeducational, psychotherapy, and multi-component interventions for caregivers of frail older adults. There's actually been a fairly recent meta-analysis on caregiver interventions. It's taken it in a different direction, and I think it's just